G'day YouTube, Warbles on a lot here. Today's patient zero is going to look at the big one, SARS-CoV2 and COVID-19. So I thought we might record that in 2 minutes time when it comes on the radio.
Julian Morrow, thanks for joining me. In just a moment we have the final episode of Patient Zero. And later this hour, the story of the pandemic that we're all still living through.
Remember airports? Walking around, killing time, buying overpriced food and checking whether your flight's been pulled? Well, imagine it's the beginning of this year. Saturday, January 19, 2020. And you're at the airport. You just cleared security and there's heaps of time before you need to be at the gate.
The palace confirmed on Saturday that Prince Harry and his wife Meghan no longer
The virus that emerged in central China has now claimed 6 lives, with warnings that number will grow.
Bowerbirds and swamp wallabies all come to listen.
What's today, kiddo? That's right.
Chinese President
You stay there.
calling for resolute
Please don't land on the camera.
to curb the spread of the epidemic and
Everything seems okay, but it's not going to be. Because somewhere in this airport, someone is already infected with COVID-19. Only they don't know it yet. Oh yeah, and this isn't just one airport. And it isn't just one person. On January 19, 2 patient zeros touched down in 2 places on opposite sides of the world. One in Munich, Germany, another in Melbourne, Australia. I'm Olivia Willis, and this is Patient Zero. Stories of disease outbreaks, where they begin, why they happen, and how we found ourselves in the middle of a really big one. In today's episode, our final one this season, we're talking about the big one, the origins of the pandemic that we're all living through. This is kind of like Patient Zero on steroids. Because the tricky thing about COVID-19, like we've seen with other outbreaks this season, is that Patient Zero is a fuzzy concept. The person that we think is the index case shifts and changes. You might catch an ember while a wildfire flares behind you. So this is our whirlwind trip around the globe, from Munich to Melbourne to Venice and Wuhan and back again. Today's show is all about what happened when we were confronted with those first coronavirus cases, where things went well, where they didn't, and whether there's anything we could have done to stop it. So, I was in the hospital. Rhonda Stewart is the head of infection prevention at Monash Health in Victoria. Her job is to make sure staff and patients are safe in an infectious disease outbreak. It's January 24, and right now, Rhonda isn't too worried.
Well, we were aware of what was going on in China, in particular in Wuhan in China, and we were sort of really preparing our hospital just in case we got a patient with the disease.
Rhonda had spent a few days preparing her hospital, Monash Medical Centre, for a coronavirus outbreak. But the disease still seemed pretty far away.
In the beginning, I think we were hopeful that we weren't going to see it because initial reports were that it wasn't easily transmitted, that there was no human-to-human transmission. It was just something overseas that we weren't going to see.
But then, Rhonda got a call.
I got a phone call saying, we've got somebody from Wuhan and they've got fever and cough. What do you think about this?
The man had flown in from Wuhan in China to visit his family, touching down in Melbourne on January 19.
He actually started to feel a bit unwell after he got off the plane in Melbourne, and he obviously was well aware of what was going on in his hometown, and his family were very concerned because they also knew what was going on.
When he and his family show up at Rhonda's hospital, they're all wearing masks.
I think that's when I thought, oh, here we go. We assessed him as we would any other person, but we put him in straight away into a negative pressure isolation room to do all the tests and x-rays and things that needed to be done. He was a bit short of breath and his oxygen levels were low, and so he got admitted into the hospital and a test was taken, the nose and throat swab, to see if he did have COVID.
The test was run overnight, and by the next morning...
I'm here to advise you that we now have a confirmed case of the 2019 novel coronavirus in Victoria, the first case in Australia.
You don't want to see that first test, but it was anxiety-provoking to think that all of Australia were probably watching us see the first patient hit our shores. Whereas before you could pretend it wasn't going to come to Australia, you could think in your mind, no, we're fine. It was that moment that I thought, right, we're in for seeing some cases now.
In Melbourne, it took 5 days for patient 0 to be identified, when the patient himself presented to a hospital and got tested. But what about that other patient 0, wandering around that airport in Munich? It's 8 days before health authorities realised there was a case in the country. And I say was because by the time they work it out, Munich's patient 0 has already been and gone.
And it was on the 27th of January when we got the call.
Merle Boehmer is an infectious disease epidemiologist working for the Bavarian Health and Food Safety Authority. They're the ones responsible for public health in Bavaria, a state in Germany's southeast.
Bavaria has about 13 million inhabitants, so it's quite a big federal state here in Germany, comparable to other medium-sized European countries.
The patient 0 in Munich airport on January 19 was a woman who had flown in from Shanghai the day before. Landing in Munich, she doesn't feel well. She's got backaches and chest pain, but she puts it down to jet lag. Before flying to Germany, she spent some time with her parents back home in China. They'd both had a mild cold, fatigue, loss of appetite, and they were visiting from, you guessed it, Wuhan. The woman had come to Munich on a business trip. She'd spent 3 days on the ground, in meetings, giving presentations, and by the time she flew home on January 22, her aches and pains had worsened into a fever. She saw a doctor when she landed in Shanghai and tested positive for COVID-19 on January 26.
The patient 0 was diagnosed in China on the evening, I think, of the 26th. She informed the company the morning of the 27th. They immediately informed their employees, as well as a local public health authority.
This was Germany's first case, but Merle knew what to do. She'd been an infectious disease epidemiologist for 15 years.
Of course, it's always a special situation. You need to adapt to that situation, but that's my job. You get kind of adrenaline rush at that moment, but you have to do your job and you have to just perform appropriate measures for that kind of setting.
The setting, in this case, would work in Merle's favour. Patient 0 had spent most of her time in Munich at her company's offices. That was good news for health authorities, but a potential disaster for the business.
They wrote an email to all their employees saying, well, there's a potential risk of being infected with COVID-19. Have you observed any symptoms the last couple of days?
And one guy is like, yeah, I actually do feel unwell.
He thought, well, yeah, I had kind of cold-like symptoms the weekend before. Maybe I caught it. Well, it's not unlikely. I had nothing serious, but maybe I should get tested.
So he does get tested. But by the time he gets the swab, he's already been back to work. The patient, a 33-year-old man, becomes Germany's next diagnosed case. The embers are catching.
In Bayern haben sich 3 weitere Menschen mit dem neuartigen Coronavirus aus China
Germany is the second country to have confirmed the virus in Europe, following France, which has confirmed at least 3 cases so far.
Immediately afterwards, our task force had a meeting and we discussed the next step. Then we decided that we are trying to identify all contacts of the first 2 cases, namely the Chinese woman and the first German case. Already on next day, 3 additional cases were identified, also employees in that respective company.
Compare COVID-19 to a disease like cholera. With cholera, finding cases and tracing them back to the source of an outbreak or cluster is a relatively simple task. The symptoms are pretty unique and almost certainly unmissable. But COVID-19 is different. Not only do the symptoms overlap with the common cold and flu, sometimes there are no symptoms at all.
You don't know who in the community is infected, and you can't identify who's infected, and you may not even know if you're infected.
Rona McIntyre is a professor of biosecurity at the Kirby Institute.
It seems to be much more transmissible, and the proof is in the pudding in how rapidly it spread around the world. This virus can spread from people who have no symptoms whatsoever.
It's not just people who are asymptomatic that complicate things. For people who do develop symptoms, it takes on average 5 days and up to 2 weeks for the symptoms to show. And in that time, before any symptoms, well, people can pass on the virus then too. That's part of what makes COVID-19 so challenging to trace. And it's important to say we know this now. Back in January, we still weren't sure whether people without symptoms could spread the virus. We'd only really just established that it could be spread from person to person. The battle for people like Rhonda and Merla, disease detectives and doctors on the front line, was only just beginning. By late January, it's not just Melbourne or Munich. Patient zeros are popping up all around the world. On January 20,
the U.S. Centers for Disease Control on Tuesday confirmed it had diagnosed the first case of the newly identified Wuhan coronavirus in the United States.
A man from Washington State is confirmed as the first case in the United States. Then, on January 23,
in Vietnam, authorities are scrambling to prevent the spread of the virus, as 2 cases have been confirmed in the country.
A father and son from Da Nang are officially diagnosed. That same day, the city of Wuhan is locked down for the first time.
This absolute bombshell that dropped at about 2 in the morning here, that this city of 11 million people will be locked down from 10 a.m. local time this morning.
By January 28, 100 people had died in China. But in Australia, we're still mostly pretty relaxed about the whole thing, or putting on a brave face anyway. The Chief Health Officer at the time, Professor Brendan Murphy, fronts the media to say there's no need for widespread quarantine protocols.
Our most important thing now is for those who have come back from China in the last 2 weeks, who developed flu-like symptoms, particularly if they've come from the Hubei province of China, they need to call ahead to their GP or their emergency department, tell them of their travel history, and get tested.
But in Melbourne, Rhonda is taking every possible precaution.
We knew at the time we didn't have any active treatment for the virus, but we already sort of knew that we had to isolate them in airborne droplet contact precautions depending on the severity of the patient. We already knew that, and that's the way we safely managed him at the beginning.
Rhonda gets to work contact tracing, trying to figure out if a patient from Wuhan has infected anyone else.
So that actually isolated him in the family home anyway, which was also very fortunate for us. So the only contacts that he had were his family members and those on the plane. And the contact needs to be, a good 15 minutes of face-to-face contact. It's not just walking past him in the street that puts anybody at risk. So the Department of Health followed up anybody that had that close enough contact or who were a couple of rows ahead or behind him on the plane.
The man and his family, their response was the stuff public health authorities dream of. Being aware of what was going on in their hometown and knowing that he had symptoms, they were super vigilant. From the moment they stepped off that plane, they did pretty much everything right. When he was feeling unwell, he arranged to see a GP in Melbourne. He called ahead and wore double masks, but he was sent home. The next day, he felt even worse, so his family took him to Monash. Again, they called ahead, and again, they all wore masks.
But once he got in the hospital, he was already in the appropriate precautions, so he didn't need to contact trace anybody within the hospital.
This man's actions defy the common narrative we hear around patient zero, that of an irresponsible case, spreading a disease around haphazardly, a concept that stretches back to Typhoid Mary and beyond. This man and his family were careful, responsible, and followed health advice to a T. Largely because of their diligence, he didn't actually pass on COVID-19 to anyone else. And in that sense, he's not really patient zero. Back in Munich, Merla's contact tracing efforts are in full swing. She's dealing with a lot of people, but most are limited to the company that the woman from Shanghai had visited. So they give her access to the employees' email calendars.
We had almost all contacts within that professional context. So we knew when person A met person B and when person B met person C and so on.
Using these meeting and event schedules, Merla and her team painstakingly reconstruct the timelines of each employee.
We classified these contacts into high risk and low risk. High risk contacts, for example, were persons who had quite close contact for more than 15 minutes, for example, or living as a couple or so. If you kiss your partner, then you are high risk contact.
The high risk contacts were told to isolate for 14 days. That's more than 200 people. Merla and her team then followed up each of them with an in-depth interview, which began to give them clues as to just how easily coronavirus spreads. A bunch of seemingly benign interactions were enough to transmit the virus. Patient 1 shared a computer with someone who became patient 3. Patient 4, who caught COVID from patient 0, passed on a salt shaker to a colleague in the cafeteria. They became patient 5. Patient 3 had a 90-minute meeting with someone who became patient 12. And patient 12, well, they went to Spain.
They located that person in Spain, and the person was immediately put into home quarantine. He tested positive. No further spread is known from that case.
That guy, he was the first identified case in Spain. Fortunately, he didn't go on to spread it to anyone else. But Spain didn't remain COVID-free for long. Meanwhile, in Munich, Merla thinks that she's managed to contain Germany's first COVID cluster.
It was 16 people in total, and it took until mid of February to contain it, so roughly 2.5 weeks. I think over 200 contact persons were identified, and they were contacted by the local health authorities, and they ordered home quarantine and instructed these persons about what they have to do next. We were able to contain it, so that was a big success.
Back in Melbourne, Rhonda is similarly convinced that she's contained the country's first case of COVID.
It's very distressing for them to have a person in their family have COVID. Difficult times for them, but they were amazing, and because he didn't speak English very well, so they were always around to help with interpreting and making sure he was up to date with what we were trying to tell him. It was very useful.
And over time, the patient gets better.
He didn't need to go to intensive care, so he was fortunate enough not to get too sick, just needed some oxygen really, which we could give him at the bedside in the ward.
Rhonda and her team at Monash had planned for this, and that planning was now paying off.
We have an amazing team. Lots of healthcare workers were involved in his care. We'd done a lot of training beforehand about how to wear the right PPE and how to manage this sort of scenario. So there was a lot of work had gone in behind the scenes before he came. So I think that preparation really helped.
If you can pick up these epidemics before they become pandemics really, really early, you can actually stamp them out, by identifying every case, tracking every contact, quarantining them, making sure that no further spread is possible.
In Munich and Melbourne, Rhonda and Merla had succeeded. But a pandemic doesn't just affect one hospital or one company.
You get that first case, the first case, patient 0. And at that point, there's only one person, right? If you find that one person and isolate them, they won't infect anybody else, and that's the end of it. But if that one person isn't found, they might infect 2 or 3 people. And that's still a small epidemic. That takes 2 weeks. In another 2 weeks, those 2 or 3 people might infect another 2 or 3 people themselves. That takes another 2 weeks, so you're 1 month down the track now. Then those people infect again, each of them, another 2 or 3 people. So you can see it's an exponential growth in the number of people. The earlier in that process that you identify it, the greater the chance of stopping it completely, not allowing it to get so big that you cannot control it anymore because it's spread to 20 countries and they're all having epidemics.
I'm declaring a public health emergency of international concern over the global outbreak of novel coronavirus. The main reason for this declaration is not because of what is happening in China, but because of what is happening in other countries.
Despite everything Whereler did to contain that first case, diligently tracing contacts and tracking the extent of the cluster, COVID-19 was spreading across Europe.
We had an exponential growth of cases during end of February and in March. We had several travelers who came back from Spain or from Italy. There was like a skiing holiday in Bavaria, and they brought COVID-19 with them, also from Austria, from a skiing resort there.
Europe's borders are porous, and at this point they were open, with people crisscrossing the continent for work, ski holidays, and sporting events.
The major event was the soccer event of Atalanta against Valencia, which was a major European Cup event.
Fabrizio Corinci is a biostatistician at the University of Bologna. It's February 19, 1 month after the man from Wuhan and the woman from Shanghai arrive in Melbourne and Munich. 40,000 football fans, soccer football, this is Europe, 40,000 fans are on their way to Milan for a Champions League match, the most prestigious competition in Europe. This match is a big deal. Atalanta are the underdogs, hailing from Bergamo in the Lombardy region, and they're playing on Europe's, some might argue, the world's biggest stage. It was the kind of game where if you had tickets to it, you wouldn't miss it for anything. Fans boarded buses, cars, trains, taxis, flights. Kids missed school to get to this game. And those who couldn't get stadium seats crowded local restaurants and bars, all hoping to get a glimpse of the action.
Here's Torres, decent cross, another chance, and still in there for Cheryshev. That's a big save at this moment of the game from Golini.
And Atalanta, the underdogs, they won. But as fans celebrated that night, they had no idea that in a nearby town, Italy's first local COVID-19 case was already in hospital.
In terms of Italian nationality, the first case that we had was basically recorded on the 21st of February.
The patient is Mattia, a 38-year-old man. He originally presented to the emergency department in a town called Codogno on February 18, a day before the soccer match, where, according to reports, he waited hours to see a doctor, all the while surrounded by other patients. In the end, he was sent home, but the next few days he felt worse. So he went back. It was 3 days later, on February 21, that he was finally diagnosed with COVID-19. By this time, he'd infected his pregnant wife, 5 staff at the hospital, and another patient.
When Mattia was found positive, he had presented as a very healthy person.
In the days leading up to his hospital trip, Mattia was feeling good, like really good. He ran a marathon, visited friends, and had dinner with a business associate. What he hadn't done? Well, he hadn't been overseas. So, although he might have been the first identified case in Italy, he couldn't have been the first person there to be infected. And yet, the media quickly became fixated on the idea of him as patient zero.
Actually, the social contacts that he had in the week before he was identified as positive, it has been hypothesized for a while that maybe among those contacts there would have been patient zero.
Mattia must have caught the virus from someone else in his social circle, which means
in a matter of minutes or hours, we already knew that there were other people infected.
Unlike in Melbourne at Monash Medical Centre, the hospital Mattia attended in Codogno wasn't prepared. Codogno is a small town in the Lombardy region in the north of Italy, home to about 15,000 people.
There weren't enough PPE within the hospital. The hospital was unfortunately a small hospital with less security issues. We had already news from China regarding clinicians in particular being infected, which happened also in Codogno.
When officials realized that Mattia hadn't been quarantined properly, they shut down the whole region, declaring it a red zone. But it was too late.
Within a few days, they also found the first case in Veneto, which was even more scary.
Veneto. That's the region Venice is in. It's a 2.5-hour drive from Codogno.
the issue with Veneto being not very close to Codogno was meaning that the disease was also spreading to other regions. So really, there was immediate fear. And unfortunately, there were those couple of weeks of delay that probably led to the tremendous situations that we have experienced in March.
You can understand the fear, right? This disease that's been declared a global health emergency suddenly shows up unannounced in a small town, and then a whole other region. The media goes wild, speculating how Mattia might have caught COVID, quickly becoming fixated on a dinner he had with a co-worker visiting from Germany. Questions start being asked about the restaurant and who else could have been infected. But then the situation starts spiraling. Cases pop up in places you wouldn't expect, small towns and isolated villages. A few days after Mattia is diagnosed, Italy registers a bleak milestone.
That was, I think, a critical day where, let's say, the mood of the country changed. You know, a very, let's say, innocent and distant person living in a small village in Veneto contracted the virus and then died from the virus. Was the first death in Italy.
A 78-year-old man. He was not only the first Italian person to die from COVID-19, but the first European. The mood shifted, and questions started being asked about how the country should respond.
I think in the same week, I was teaching in Bologna, and there was also a huge question mark on whether the schools had to be closed or the universities had to be closed.
The next day, Fabrizio got an answer. Late on Sunday night, Italian Prime Minister Giuseppe Conte holds a press conference.
It was basically declaring the state of emergency for the whole country. That was the scariest moment. And the lockdown started on that day and then lasted for 75 days.
In a matter of days, the world had changed.
Finger pointing, leaking, and relentless criticism. The furor around the Ruby Princess continues to grow.
Coronavirus is now widespread on several cruise ships. The Diamond Princess, after docking in Japan, floats in its own offshore quarantine with nearly 4,000 people on board. By early March, 697 passengers will be infected, and 7 will be dead. At the same time, the Ruby Princess cruise ship docks in Sydney, fresh from a tour of New Zealand. All passengers disembark, despite some showing symptoms of COVID-19. In just 2 months, we've come a long way from those airports in Munich and Melbourne. In Italy, cases quickly spin out of control. Within a week of Mattia's diagnosis, 888 people test positive, and there are 21 deaths. But the Italian media remains fixated on Mattia.
Abbiamo questa notizia novità sul paziente zero. Veneti, Lombardi ed Emiliani. La Grecia ha vietato
zero, quello ancora senza nome e che per
a parlare di questa cosa perché Mattia è il paziente numero 1, è arrivato nel vostro ospedale.
Hard to say. I mean, it was really repetitive statement about chasing this person. Where was Mattia? Which restaurant he ate?
There's something about this ordinary guy from a small town in Italy that hooks in people's minds.
I could say that possibly 1 week there were, at least 10 different reports and news every day. I was really obsessed about this.
There was a strong belief that if you could just find patient zero, you could stop COVID-19 from spreading. But it's not that simple. In infectious disease outbreaks like COVID-19, you've only got a short window of opportunity to put out spot fires as they pop up. If people are identified too late, chains of virus transmission can quickly spiral out of control. When community transmission becomes widespread, as it was in Italy, trying to identify the first ever spark becomes less important than trying to stop the whole country going up in flames.
So it looks so nice because it's like a movie where you actually find the person and you find the solution of the plot. But in reality, this never happened.
By the end of March, about 6 weeks after Mattia first presented to the emergency department, 12,500 people in Italy would be dead from coronavirus. Doctors from the Lombardy region in Italy's north likened it to a war.
It was a terrible period. It was a terrible period. We had this moment where
when were the young patients that I couldn't have? The young patients that have died.
With or without Mattia, Lombardy became the first COVID-19 epidemic centre outside China. Remember that football match? The one between Atalanta and Valencia, with over 40,000 people attending? As friends and family and total strangers hugged and kissed and celebrated their hometown's victory, coronavirus silently made its way through the stadium, the restaurants, bars and house parties. The match later became known as Game Zero. We don't know how many people were infected before that match. The data doesn't exist. But after the match, 7,000 people tested positive, and more than 2,200 died. The mortality rate in Bergamo became the highest in the country.
Statistics that have been published by the National Institute of Statistics in Italy found that Bergamo had a 5 times higher mortality compared to the 5 years before 2020.
Experts believe the football game is part of the reason why. But that's not all. The Spanish team come from Valencia, and it's believed the first case of COVID in Valencia was a journalist who travelled to Milan to attend the match, one of the earliest COVID introductions to Spain. More than a third of the visiting Spanish football team would go on to be infected. One expert called it a biological bomb. According to Fabrizio, a lot of what went wrong in Italy in the early days of its response can be put down to how the country's health system was set up.
You realize that our systems were not meant for infectious diseases. You keep people in the hospital where they actually can get infected in large amounts. And when you have huge numbers in these hospitals, all at the same time, the system can collapse and the hospitals can also become the major source of infection in the community. That was exactly what was found.
Not only did these hospitals become hubs of infection, many were stretched beyond capacity, as thousands of people poured in, many seriously unwell. Doctors were forced to make impossible decisions about who should live and who should die. And as for the public health authorities trying to stem the tide of new infections, well, they faced enormous challenges too. Italy's health system is highly fragmented, with little connectivity between regions, which makes effective contact tracing a near impossible task.
The data are not interconnected. So when a person has connections with another institution or maybe goes to another hospital which is across the border, then this data wouldn't be able to communicate. This explains how difficult would it be to trace the disease in a population of 60 million.
As the COVID-19 pandemic spreads and our understanding of SARS-CoV2 develops, the timeline of patient zeros around the world gets pushed back earlier and earlier. In France, testing reveals their suspected patient zero was far from the first case. And in Italy too, there's speculation coronavirus could have been circulating for months. A tourist couple from Wuhan who had been driving around Italy in late January tested positive in hospital. At the time, it was thought they didn't spread it to anyone. But as authorities started to dig deeper, they became less sure.
They might have stopped on the way, they might have visited restaurants, they might have done things that haven't been actually explored by the inspectors that then made the investigation. But they were found in Rome, and it has been never mentioned whether they infected others, even in Rome.
There were critical missteps taken in the early days of Italy's response, but ultimately there are a lot of reasons why things went so wrong. Mattia eventually recovered after 18 days in intensive care, after which the government used his fame to record a safety message for the public.
People must learn from my experience that staying home is crucial. Prevention is essential to contain infections. This can mean removing yourself from loved ones and friends, because we don't know who might be infectious.
But it was too little, too late. From March to April, embers became bushfires, which became infernos in Italy, Spain, Brazil, New York, and then across the United States. According to the World Health Organization, we went from 100,000 cases globally on March 7 to over 1 million by April 4. But where did this all begin? Around the world, as everyone wondered exactly where this outbreak started, all eyes turned to a seafood market in Wuhan.
Initially, we thought that it arose from a cluster of cases in December in Wuhan, and the seafood market was given a lot of prominence because about half the initial cluster of cases had been to this seafood market, where some of the environmental samples, when they swabbed the surfaces, etc., were positive.
The seafood market makes sense, at least at first glance. We know that viruses circulate in animals, lots of viruses, and occasionally these spill over to humans. At the market, people were in close contact with animals, including unusual and exotic species. So the idea that the virus first emerged here, well, it made intuitive sense. But intuition is one thing. Epidemiology is another.
There were people who were getting sick in Wuhan who were not directly around the wet market, so that it doesn't necessarily look like it started there and then fanned out from there.
Carl Zimmer is a science journalist and columnist for the New York Times. He's written a book about viruses and has been covering the coronavirus pandemic.
One way that you can get to the origin of a virus like this is to look at the viruses that you get from people who are sick with the disease, and then compare them in terms of their genes. Because, they're all related to each other. They all descend from a common ancestor. And as the virus gets copied in different people, there are mutations. And so if you kind of add up those mutations, you get a clue as to how much time has passed since they all came from a common ancestor.
It's a vast family tree. And so far, it points back to a common ancestor in November 2019, a month before the seafood market.
It's possible that it was there in China months before, and maybe was just kind of going from person to person in a very low level, and we just haven't got a record of that. So certainly if you want to say, like, well, of all the virus samples that we have on hand that we can actually look at, when was their common ancestor? I'd say November 2019.
If we'd been able to find and contain the infection at this point, would it have made any difference?
In epidemic diseases, the size of an epidemic can grow within weeks, so delay does matter. The sooner you get to an epidemic at the origin, the greater the chance of stamping it out completely.
With better surveillance systems, maybe we could have caught these earliest cases as they were happening.
Even after a virus spills over into our species, there are lots of things that can be done to stop it quickly rather than letting it get out of control. There's no excuse to just shrug our shoulders and say, oh, there's nothing we could have done. There's lots we could have done.
But is better early detection enough? We can go back even further to the origins of the disease itself. SARS-CoV2, like other coronaviruses, is thought to have originated in bats, jumping to humans either directly or through another species. As humans push into natural environments and live in closer proximity to animals, there are more opportunities for viruses to spill over and infectious diseases to spread.
If you go and take a look at farmers who live where these particular Chinese horseshoe bats live, near their caves, and you check them for antibodies, you will find, in a surprising number of them, antibodies to bat coronaviruses. Not SARS-CoV2 necessarily, but others. So in other words, these viruses are pinging against us all the time.
The ever-growing expansion of human activity into animal environments, driven by agriculture, by development, by deforestation, makes the spillover event all the more likely. When viruses do emerge, our increasingly globalized world means they can spread faster and farther than ever before.
We have made a big mistake in where we invest our resources, and we're paying a horrible price for it now. As a global society, we need to be monitoring viruses in wildlife. It also means better healthcare systems and healthcare surveillance so that when a virus does happen to sneak over the line into our species, we are ready at the outset. and that's certainly what all the experts have been saying for years, that there are lots of things that you can do, and honestly, they're not that expensive. I mean, we're looking at an event that's going to cost the world many, many trillions of dollars, and you could have easily prevented this for maybe, say, $20 billion. So these are all things that if we don't think about this seriously for the next pandemic, it's like we're sort of socially suicidal.
There's always going to be a patient zero for as long as we're living in close contact with animals and exposed to the diseases they carry. Identifying a patient zero isn't going to stop this pandemic, but what we learn this time might help us prevent the next one. Are we listening?
You can comfort yourself by saying, oh, this is a once-in-a-century thing and this won't happen for another century, but you're fooling yourself if you think that. It's true that there's nothing quite like this since the 1918 flu pandemic, but all the conditions are right for this to happen all over again with another virus. We know, for example, that bats are full of coronaviruses that are very much like this one. And they could spill over, and whatever immunity we develop to this particular bat coronavirus may or may not work against another one. And there are other species that have lots of their own viruses. So this will happen, I would say, probably will happen within the next decade. So are we going to be ready for it the next time or not? That's the question.
That was our final episode of Patient Zero for this season. If you liked the series, we'd love you to leave us a review in Apple Podcasts. In this episode, you heard from Rhonda Stewart, Head of Infection Prevention at Monash Health, Merla Boma, an infectious disease epidemiologist at the Bavarian Health and Food Safety Authority, Rainer McIntyre, Professor of Biosecurity at the Kirby Institute at the University of New South Wales, Fabrizio Corinci, a biostatistician at the University of Bologna, and Carl Zimmer, a science journalist and columnist for the New York Times.
And now you get to hear from Warbles on a lot, who sat the New South Wales Nurses Registration Board final exam for general nursing candidates in October 1983. And as a student nurse, there were two things that I sort of got a bit of a reputation for being unusually good at. One of them was orthopedics. Probably the absolute high point of my orthopedics career was the day when a fella who these days is the highest priced brain surgeon in Australia, Charlie Teo, ran the length of the cafeteria line waving two $10 notes, calling, "Hey, student nurse, student nurse." I was just back from a fortnight's holidays. He'd been looking for me because I'd told him that a patient had a fractured scaphoid bone. It's a little baked bean sized thing at the base of your thumb. And he reckoned you couldn't diagnose that until 2 weeks had passed. And I told him I thought the bone was broken. He had an x-ray taken and we had a bet. No fracture showed on the x-ray. I paid the bet. 2 weeks down the track, and they did another x-ray because the patient was still complaining, and behold, after a fortnight, necrosis of the proximal fragment of the scaphoid bone confirms the fact that there is a break because the blood supply comes in through the distal end, the far end. So if you break the thing in half, the near end dies. And it stays highly calcified because it was working, it was doing a job. The far end, because it's hurting so much, it loses all of its calcium and it becomes almost transparent on x-ray. So that's the only way that you could diagnose a fractured scaphoid. And therefore, Charlie Teo wanted to know how come I could figure it out on the very first day. And it was just down to taking a good nursing history and knowing the anatomy and the physiology and the dynamics of the accident in which the bloke put himself in hospital. So yeah, I was good enough at scaphoidology that I taught it to Charlie Teo back when he was an orthopaedic registrar. And I, at the time, was a second or third year nurse. Third year nurse, obviously. Just about to finish. The other thing I was sort of infamous for was infection control, barrier nursing. trying to deal with the terrifying multi-resistant Staphylococcus aureus bacteria, methicillin resistant in particular at that time. Now, I started my nursing training at Tamworth, and after 3 months at Tamworth, they had a gutful of a loudmouth ex-helicopter salesman, and I was framed. I was fired because of an accusation that a male nurse had said something, and the patient concerned hadn't been on my ward for 3 days, but because of a paperwork stuff up, he was listed in their books as being on Ward 2, because that's where we had transferred him from to go to intensive care unit. It was a bloke in intensive care who said the thing at the cafeteria with the patient's wife behind the nurse who said the thing. It wasn't me. But anyway, they were looking for an excuse. I got fired. 2 weeks later, I started preliminary training school again at Concord Repad. So I was pretty good at preliminary training by the time I'd done it twice in 6 months, and it takes 2 months each time. After, I think it was a month on the wards, might have been 2 months on the wards, we had, after 1 month on the wards, we had a little short 10-day lecture block called 1A block for practical procedures. And in order to be taught how to do a dressing on a wound, you had to understand the principles of infection control, and therefore you got taught a pretty hefty chunk of microbiology for a beginner. And part of that involved a lecture from the hospital's professor of microbiology. He'd come on down and talk for an hour and then answered questions for an hour. And he not only communicated how the bacteriology worked, he also communicated how the hospital politics was working. And he left us with the impression that what the hospital needed was to set up a little unit somewhere where every ward could send their people who had multi-resistant staph A, and they could be barrier nursed in one unit. But the hospital board didn't want to do it that way. The hospital board wanted each patient to be nursed, barrier nursed behind curtains in the Nightingale wards, which really weren't designed for barrier nursing because there weren't that many things that were contagious like that. You know, a fast-moving pneumonia plague. It just completely defeated them. They nursed that with cotton masks and boric acid and gloves and stuff. And they did a reasonable job. But anyway, I left practical procedures block filled with the fervour of a zealot, thinking that what we needed was a unit somewhere in the hospital. And behold, I was on Ward 610, which at the time was a male abdominal surgical unit. And the layout of the Concord Hospital multi-wing thing is that you have 3 bays of 8 patients that you can see from the window of the nurse's office. And back behind the nurse's office, on the corridor leading to the elevator core of the building, you have a single room behind the nurse's office with a little office-size room with 1 bed in it, and that's where perhaps your sickest or noisiest patient might be getting stuck to give everybody else some peace. And then further back, pretty much opposite the pan room and the bathroom, there's another little ward in there that's got 6 beds in it. So I rock up on a Friday afternoon and I got stuck specialing a staph positive patient in room 25 with bed 25. 1 nurse, 1 patient. That meant the other 2 people on evening shift were run off their feet while I dealt with just 1 patient. Couldn't go near anybody else because I was barrier nursing them. Infection risk. We were trying to contain this stuff. Rock up the next morning at 7 o'clock, and this time I'm out the back with the little 6-bedroom, and I've got the knowledge that 3 clean patients, 1 empty bed, and 2 blokes who've got multi-resistant staph on their swab. So I have to do absolutely everything in the morning jobs routine for the 3 people who got clean wounds, and can't even feed the other 2 blokes or do anything for them, make their beds, nothing like that. So it's a real pain in the arse. And by the time I get to morning tea, when I hear that there are people being discharged because it's a Saturday morning, and one of my fellas who's clean, he's getting discharged, and there are some people in the main ward getting discharged, so they're going to have to carbalise beds. I suggested to the registered nurse in charge of the ward on the Saturday morning, why don't we just sort of move those 2 patients with positive swabs from the middle of the main ward where you're trying to barrier nurse them behind curtains, put them into the 2 empty beds that I'm going to have by midday because I've got these people who are being discharged, and that way one person can be looking after 3 people with staph, and then we can get that fella from bed 25 and put him in here too, and that way only one nurse is in one room and there are 6 beds and 5 patients, and 5 patients have all got staph. Why don't we do it that way? And that seemed to be a reasonable thing. And I came back to work on the Sunday, and somebody had been sent to the ward with staph from a different ward. They'd been having an operation and arrested on the table, and the operation was half done. And yeah, so there was, it was a lovely mixture. And then on the Monday morning, I'm at work at 9 o'clock, and the charge nurse arrives, and she nearly had 3 cats and 4 kittens and a porpoise, at the fact that she walks onto her ward, which is supposed to be a clean surgical unit, and there's pink gowns hanging up on drip stands and signs saying staff unit, you know, barrier nursing in process, put on a gown or don't come in, and gloves and a mask and a hat. And yeah, she immediately demanded to know who, by whose authority this had been done. And of course, none of the registered nurses could say that they had done it because, oh, well, I just transferred a patient and I just transferred a patient. I think she figured out that I'd been the one who'd started it because I was the one who was most enthusiastic, and she tracked the times and who'd worked when and whatnot. But anyway, that meant that for the rest of my time on Ward 610, I'd started it so I could bloody well work there. And her goal in 1981 was to clean up those patients and clean the room and carbolise it, and that was it. The staff unit would be no more. So in about 1983, when it had been up and running for 2 years, it was retasked with being the infectious burns unit, because the clean burns unit was on Ward 630 across the lift well, and they didn't have the facilities to barrier nurse one patient and have a clean patients beside them. So it became the infectious burns unit. And yeah, that was 1983, and 37 years later, it's still going. It's been up and running for almost 40 years because I started it in 1981. So I know a little bit about infection control, and I would say to you solemnly that whereas that radio broadcast they mentioned 2 weeks as being the end of your incubation period, at the end of 2 weeks, I think it's 97.5% of patients who are going to test positive have tested positive. If you go out to 21 days, then 99.5% of everybody who's going to test positive has tested positive. And if you spool it out to the extreme end of the bell curve, the current record is 38 days between being exposed to coronavirus and testing positive. So everything that they said, just bear in mind that there's going to be a little rat tail that's still there even when you think you've cleaned it all up. And at the moment in Australia, we're undergoing a bit of a political paroxysm of incompetence on the federal level, trying to pressure the Victorian government, and there are 2 different political parties. The federal level, we've got a Liberal National Party, and the Liberal Party is the party of the shareholders and the investors and the bosses. The National Party is the party of the farmers and loggers and miners. They're in government. The Labor Party is the party of the unionists, workers, blue-collar types. At the moment in Melbourne, in Victoria, it's the Labor Party who are forming the state government, and they are attempting to deal with coronavirus when Melbourne was the first place in Australia to start having to deal with it, but they're trying to deal with it via a health system which has borne the brunt of the laissez-faire, neo-capitalist, right-wing, pseudo-conservative, because what the hell have they ever conserved except their own right to exploit the workers and trash the environment, party of deregulation, party of privatisation. And like it was under the Liberal National Party that aged care was transferred from a system wherein at the states were responsible for the nursing homes, and the nursing homes were called nursing homes because you had to have a registered nurse on shift all the time, and they changed that. They were run by state governments, paid for by state government. There was very little private nursing homes and private aged care because, you know, there was a pretty good system. They changed that to a system whereby private companies could run a nursing home for profit, and they didn't have to have any specified level of care because the wording was changed to say that they had to provide an appropriate level of nursing care. So some of these places didn't have a registered nurse on shift. They pushed for the casualisation of the workforce so that nurses' aides and assistants in nursing and even registered nurses can't get enough shifts and enough hours to make a living at any one of these hospitals, and private hospitals are the same. And because of the rise of agency nursing, where somebody sits and has a list of nurses on their roster, on their call-in books, and when a hospital says, I need a nurse in 3 hours for this, they ring up and the first person on their call-out tree who answers gets the job. This is all massively degraded the resilience of the system to be able to cope with actually having all the beds full. That's the other thing. Back as early as the 1980s, like 1984, I couldn't make a 25-bed hospital operate properly if there was any more than 20 patients in it. Patient number 21 came in, it fell to pieces. By patient 23, it was so bad you had to be calling in extra staff to help do in the morning, get out of beds and feeds and showers and stuff. Mentioned that to a pharmacist who happened to be on the hospital board in Glen Innes, and he said, oh yes, and he yawned, and he said, that's because Hunter New England Regional Health mandates that you're only allowed employ enough permanent nursing staff for 75% of your bed state. And the system used to kind of function like that when I was a nurse. In 1987, they completely destroyed it, and then 1997, they did even worse things to it. It was the Liberal National Party governments who pushed for the downsizing of all the civil servants, so there weren't enough staff in the health department to have anybody who'd been trained as a nurse and was now a bureaucrat who could go out and run an infection control program at a quarantine hotel. So they rang up a telephone book extracted list of private security companies and gave them the job without a tender, and they subcontracted it out to the lowest bid tender. So you got utterly untrained, inexperienced people who had no idea what they were doing, and the quarantine broke down in Melbourne. And now, when Melbourne went up to 780 cases in one day, and they've got it back down to somewhere between 40 and 100, you know, they had 55 today and 40 something yesterday. Our prime muppet, Slow-Mo ScoMo Scott Morrison from marketing, he keeps pushing Victoria to open up because the economy. Down there in Melbourne and in Victoria, where everybody listens to bloody Sky News, which is the clone coming out of Rupert Murdoch's Fox entertainment industry, they've been putting shit on Dan Andrews, the Premier, because he's Labor and Labor is socialist, and you know, Rupert Murdoch doesn't like the forces of leftism. They have been putting shit on all of the doctors and all of the epidemiologists and all the virologists who ever wanted to lock down early and lock down hard and have a strict lockdown, because quarantine with exemptions is not fucking quarantine. It's bullshit. You know, somebody who wanted to go from Tweed Heads to Brisbane can't do it because the border's closed. Well, I'm sorry, but New South Wales is capable of delivering twins, even if the preferred doctor is in Queensland. Somebody else wants to go and visit his sheep in New South Wales from Victoria because he thinks that he has to hand feed the sheep with the bales of hay he's got sitting on his front lawn. It doesn't occur to him he could ring up a stock and station agent in any one of the 2 or 3 nearest towns to where his sheep are living across the border, and he could contract somebody else to go and feed his sheep so that his sheep could get fed, business could be transacted across the border. Yes, it would cost him a little bit more, but it was not nearly the case as was presented by him to the national media and broadcast all over the country that, oh, the bloody health department wants me to truck me bales of hay to Melbourne and cargo air freight them to Sydney and then truck them back to the border. That was never suggested by any public health employee that I can imagine. That's just what he has chosen to make of their suggestion, that the only way is by air. You can't go across the border because we're trying to stop people from going across the border. All the people who are saying, oh, but boo-hoo, sob, I'm 500 miles from Melbourne and we haven't had any cases here, so why should we be locked down? The reason you've had no cases there is because you are fucking locked down, because you still don't know if you've got what you'd call occult cases. Doesn't mean they practice the dark farts. It means it's hidden. It's secret. You've got cases that you're not seeing because you get 3 or 4 people have an asymptomatic case and then one of them gives it to their grandmother and you have an outbreak somewhere. And the only way to exterminate a virus that is as infectious as this little thing apparently is, it's not just droplet infectious, it's airborne infectious. It's not a case of when you sneeze and you watch the Curlian photography and you see the bubbles of snot drops going out there for 2 or 3 metres or 6 metres. It's not like that. It's more like if you're 50 metres away and you see somebody light a cigar and a minute and a half later you can smell the Cuban tobacco burning. It's that kind of airborne infectious. That's why your N95 mask is only going to stop 95% of it, because some of it is going in on the air molecules that are getting sucked in the tiniest littlest gaps. So yeah, wearing a mask is better than not wearing a mask. It'll probably stop 65% of the infections, even if it's not an N95. An N95 theoretically worn properly should stop 95%, but a mask might stop 60%, largely because it'll catch the snot drops and a lot of the little viruses coming out of people who don't know they've got the virus. You want the masks on people who feel good, because if they don't know they've got the virus, they're going to feel good anyway. But the busyness as usual lobby is going fucking bananas. They keep demanding to see the modelling and demanding to see the data, which cause the politicians, mind you, to actually listen to the medical fraternity. They don't appear to be capable of grasping the idea that we've already done it your way, dickwit. We've already postponed the lockdown until we went from 5 cases a day to 20 cases a day. Oh, fuck, we're over 50 cases a day. We've got to have a lockdown. Then with the lockdown, we allowed people to have exemptions, unofficial ones, like go to a funeral, said the guard, the quarantine guard, to the patient he was supposed to be keeping in quarantine. So we had a really slack lockdown with holes in it all over the bloody place. And then the busyness as usual lobby said, oh, that's it, like your curves come down. Now we can tolerate having 20 cases a day or so. Open everything up again. And they insisted on doing that and celebrating it. Both Dan Andrews and Slow-Mo Scott Moron from marketing, they celebrated the fact that Victoria was opening up early, and then it went into massive lockdown again, 700 patients a day, because it had got out of their quarantine motels, it had swarmed through the community, and the security guards who were working as minimum wages guards with no training, they were also working as Uber drivers, and they were in relationships with minimum skill level nurses who were working at multiple aged care homes. And all of the cases in Melbourne came from that one quarantine failure. And now at 55 cases a day, our moron-in-chief in Canberra wants, for the sake of the economy, to have another go at opening early before we've actually exterminated the virus, because, people's profit and loss ratios are up to shit. There's employers having to tell the employees that there is not any job for you yet, and we don't want to keep printing money. We're too busy continuing on with all sorts of other shit, like buying all those F-35s from the excited status of Norte Armed Americano, and the nuclear submarines, sort of backwards retro converted to diesel from the French. Yeah, we've got to do all that, but we can't borrow a few $1 billion in order to keep today's citizenry living in their houses. And putting a ban on evictions doesn't help the landlords who are paying mortgage repayments on the property that they're renting. We've set the entire commercial and financial system of our economy, of our society, up to have no resilience. in the face of any kind of interruption to their trade. And it's never occurred to any of the people who left school early and didn't go and study biology in the last 2 years of high school, year 11 and 12, what the Americans are pleased to call a college education, because their high school ends at year 10. The people who didn't study biology in year 11 and 12 of high school, they don't know how the world works. They think we live on planet cash register, and nothing is allowed to get in the way of their busyness model and their profit forecasts. They can't cope with the idea that if you don't lock down for 28 days after you get down to the last known case, then this virus is going to jump back up and reappear. And next time, the third wave, it will be as much worse than the second wave as the second wave was worse than the first wave. That is how this shit works. They're still trying to bloody suppress Staphylococcus aureus in the multi-resistant staph unit that I set up 39 years ago at Repatriation General Hospital Concord in Sydney, Oz. The absolutely only way you're ever going to get your economy back is first deal with the medical emergency. After you've dealt with the medical emergency, then you can build your economy back up within whatever limits you need to set in order to slow the onset of any reappearance. That means that you're not going to get away for a very long time from the fact that anybody who wants to fly into Australia for any reason, business, tourism, matters of state, they're going to have to go into quarantine at the airport of departure, and they're going to have to pay for themselves to be quarantined over there for 2 weeks and tested negative after 2 weeks before getting on the aeroplane to come here. And when they get here, they're then going to have to be bloody quarantined again at their own expense for another 2 weeks. So you're looking at a month quarantine before you're allowed to effectively go roaming in our community after you've come in from overseas. So anybody whose business plan depends on having any kind of sudden reinstitution of international tourism, I think they're dreaming. I think them days is gone. They ain't gonna be coming back any no more. The annual clap catching expedition to Bali, or visit Aspen, Colorado to break your leg snow skiing, or go to New Zealand mountain climbing and fall off planet Earth on an overhanging canyon or something. Them days is over. Have a staycation. Maybe sit in your backyard and watch the potatoes grow beside the carrots and the beans and the peas, because otherwise what the fuck else are you going to eat when the supermarket is no longer any good for hunting and gathering? 4 more years. Global Vial Ages economy has contracted 16% in 8 months, as 2% per month, and it's been a fairly steady, gentle downward implosion. If that keeps on 4 more years, there won't be any international global trading economy. But if you want to bring it on, just try and reopen straight away and see how many men over 50 who know how to fix things and keep things running you can kill in how short a time. That ought to be interesting. Have you noticed the grey hairs on all the people who are working as contractors for Telstra, keeping the telephone system running? Not many young fellas there, because it's all being done by contractors, and contractors don't have apprentices. Kill all the old bastards who know how stuff works, and you'll see a fairly short shelf life for the rest of society, I think. But I might be wrong. Anyway, I think the longer and stricter and harsher the lockdown, the better, because everybody who keeps trying to find loopholes through which they can beat the system is just making the whole thing go on harsher in terms of the outcome and longer in terms of the need to have a lockdown. And if they try really hard, they might be able to crash civilization all in one go. Warbles on a lot to YouTube. Such is life. Ned Kelly, such is life. Ciao.